Thank you so much, everybody, for being here at our PCA lecture. Daniel Sewell is a professor of clinical psychiatry at University of California, San Diego, and he's also director of the Memory, Aging, and Resilience Clinic. We like that, Resilience Clinic. And he's going to talk about his work with patients and behavioral signs that he kind of helps figure out with families.
Okay, so switching gears then, we're going to speak now about what can happen in terms of a person's emotions and what can happen in terms of the psychiatric arena when someone's living with PCA. Also, though, I'm going to be talking about what may be happening to the caregivers involved, because in some ways, it's been my experience that the journey is really parallel, and I'll try to spotlight some of those parallels as we go forward. So it's really important that we speak about this, and perhaps that's stating the obvious, but you know, we don't yet have cures, and we yearn for them desperately, and I'm an optimist, and I do think that we will have some pretty powerful treatments that will come down the pipeline eventually. But while we wait for those, there are things that we can do. And to me, one of the things that we can do and do better than we're doing now is really focus on quality of life, and more specifically, focus on the part of life quality that might be eroded by emotional and psychiatric symptoms that can occur in the individual living with PCA, and sometimes even in those that love that person and care for that person. And we know that these symptoms really have an impact on quality of life, but these symptoms can also have other unwanted outcomes, like sometimes making it difficult for the person to remain in his or her home, or these symptoms can trigger unwanted and difficult admissions to the hospital that we just as soon like to avoid. We know that these symptoms can definitely make caregiving more challenging than it otherwise would be. And we know that these symptoms can consume a lot of time in terms of caregiver time, and really can limit the other things that they might want to prioritize in their life, like things like perhaps they're having a career or continuing to work in a professional way. So one of the things that we see a lot is grief. And we see that both in the individual with the illness, and we see it in those around the person. Grief really occurs whenever any of us experience loss. And certainly being diagnosed with this condition represents a big loss. It represents a change in how we've understood ourselves to be. It represents a change in terms of the arc of life that we might have been dreaming about as we looked ahead in our life and planned for the next phase of our life. And the loss is pretty big. And it affects both the person and the person, like the spouse or other members of the family. And one of the things that we, I think, can do better is recognizing the grief and making sure that people have a way of working through the grief that's helpful and successful. And I put here on the slide different feelings that can be a part of the grief process. And I want to make sure I remember to credit Elizabeth Kubler-Ross, because she was one of the very first people who really began teaching us and talking to us about grief reactions and the different phases of grief. And she really identified these 5 phases of grief, or actually you might even say 5 different emotions that can occur when someone is grieving and experiencing loss. Kubler-Ross initially thought that people would go through these different phases in an order, kind of in a certain pattern, but we now understand that that's not true, that people don't move through them in a linear manner, that people can move about up and down, back and forth. They can spend time in one and move to another and then go back to a previous phase of the grief. But whatever the order is, we know that loss often triggers denial, anger, bargaining, depression feelings, and hopefully we want someone to land in a place of acceptance, not being happy about the loss, but being able to go forward without the loss really being a huge problem day to day. So denial, of course, is when someone hears bad news and they don't want to believe it. We see that. Particularly when you're given a diagnosis with PCA, it's very tempting to believe that it's not really true and to pretend that it's not true, although, of course, that doesn't work indefinitely. There's a moment when the symptoms are just too prominent to be denied. It's also very understandable that someone who is presented with this diagnosis would be very angry about it. Who wants to be told that they're now going to be living with this very challenging condition? That's a lot, and none of us would necessarily want to have that be a part of our future. Bargaining talks about the phase of grief where we try to think, well, if I just do this or I just do that, maybe the illness will go away or maybe the illness will get better. And so we try to make some kind of bargain that will somehow make things seem better or feel better than they might otherwise be. Depression, of course, is the sadness that we feel because of what we understand the illness may mean to us and mean to our families. And then the last stage, of course, is that stage of acceptance. When someone's grieving, what they need is not that complicated, but they need opportunities to talk about their feelings. They need opportunities to put those feelings into words. And sometimes we can help each other because sometimes strong emotion jams our circuits and we lose access to the words that we would otherwise speak. Sometimes a person with the illness may actually have some changes in their brain that make finding the right words more difficult. And if that's the case, we can actually make reasonable guesses about what someone might be feeling using contextual cues, looking at their face, looking at what words they have spoken, and sometimes just being able to say out loud the feeling that we think that person may be experiencing in that moment can be amazingly helpful. No matter where we are in our journey through life, feeling understood is a pretty special experience to have, and in my opinion, probably doesn't happen often enough for most of us as we go through life. And so we have to expect that part of the journey with PCA will involve grief, and I think if we expect it, then we can be nimble, and when we see it, we can respond. And again, the best response is just to listen in a very neutral or supportive way, looking for opportunities to reflect back to the person who's grieving the most prominent feelings we think that they may be experiencing in that moment. If we miss the mark a little bit, chances are we'll get corrected, but that's okay, because with that correction, then you can be even more precise in your efforts to really let that person know that you get what they're feeling. You understand that these are the feelings that they're struggling with, and they're not alone with those feelings because now you are aware of them and you've heard them and witnessed them. And it seems so simple, but yet it can be so important and so helpful. Now, the one other piece of this topic I want to highlight, though, is grief in PCA isn't just a single moment, because what happens as the illness goes forward is that there are losses, and then there are additional losses, and then there are additional losses. And so it's important that we don't just think, okay, the grief is over, we'll move on. I think we have to be prepared to recognize that grief can pop up at various points along the way. And so with each change, with each loss, with each struggle, there may be grief that needs further attention. Now, another thing that's very common in individuals living with PCA are anxiety feelings. And this can be from a number of different causes. Certainly, most of us who have lived our life with vision, when that begins to change, that in and of itself would make any of us feel anxious. Many of us who have normal vision, we just take that for granted. We just, don't even think twice about it. But if something that you've depended on and needed and really valued through your life suddenly begins to change in ways that make your life difficult and puts you at a place where you're less able to take care of yourself, to be independent, that's going to trigger anxiety for sure. And then also a source of anxiety can just be that you understand that you have the illness and you understand the basics about it, and knowing kind of what might happen can be a source of anxiety. And we know that the pattern of anxiety can vary over the course of illness. In some individuals, especially if they're not linked to appropriate treatment, the anxiety can be kind of continuous. In other instances, it may be episodic, and it may pop up with a loss, be dealt with, and then simmer down for a while. So we see different patterns of anxiety feelings appearing, but they are fairly common. We even sometimes will witness in individuals a form of anxiety that we call a panic attack, or maybe if they have a lot of panic attacks, it may even rise to the level of what a psychiatrist would identify as panic disorder. What I put here on this slide are some of the defining features of a panic attack, and there are actually 13 different possible symptoms that can occur in someone who's having a panic attack, although you only need 4. Most of the time I note that people have many more than just 4. The minimum would be to have 4 out of these 13. One of them can be that you have just this fear that you're immediately at risk of dying. But beyond that, we know that panic attacks are defined by things like heart palpitations, racing heart, sweating, trembling or shaking, feeling short of breath, feeling like you're choking, having chest pressure or pain, upset stomach or nausea, dizziness, even sometimes feeling faint or lightheaded. You can have hot flashes or cold sensations. You can have numbness and tingling. You can have moments where you don't think that things look real anymore, or you can have feelings that you're not really connected to yourself anymore. And you also, a person with panic attack may also think that they're about to lose control. We know that panic attacks correlate with a release of adrenaline into the bloodstream, a large release of adrenaline. And adrenaline is the molecule in our bloodstream that is there to help us in moments where we either fear that we're going to have to fight to protect ourselves, or we're going to have to run like crazy to get away from danger. So panic attacks actually, in some ways, might be viewed as adaptive if you literally are in a moment where your life hangs in the balance. But when they happen outside of that context, these experiences can be very painful and very disruptive. The good news about panic attacks and panic disorder is this is something that we could treat. We do a pretty good job in the field of psychiatry treating panic attacks and panic disorder. But to treat it, of course, the first step has to be that it has to be recognized. It has to be diagnosed. And then the second step, of course, is finding a clinician that knows how to treat panic attacks and panic disorder. Sometimes medicines aren't needed. Sometimes panic attacks can be treated through psychotherapy. Sometimes medicines are the right answer, sometimes a combination. But the most important thing to know is that anxiety I consider to be low-hanging fruit in this situation, and something that really should not be ignored, but something that should be quickly dealt with, and most likely involving a clinician that can help sort through what's going on, and either he or himself prescribe the right treatment or make a referral to someone who does know how to treat anxiety and does know how to treat panic and panic disorder. Another possible psychiatric challenge in someone living with PCA would be variations of depression illness, and it can be anywhere from mild depression to the most severe type of depression challenge, which we call major depressive disorder. And on this slide, I've summarized some of the defining symptoms of a depressive episode, a major depressive episode. There are 9 different symptoms that may occur. Only 5 are required to be diagnosed with this, and I've listed them here. The symptoms, to make diagnostic criteria, the symptoms have to be significant enough to cause distress or impairment, and we have to make sure that there's no other cause for the symptoms. But once we've done that, if we really do feel that there's a major depressive episode present, again, this is low-hanging fruit. This is something that thankfully in the 21st century, we have really good tools in our toolbox to treat. But the first step, of course, just like with anxiety, is recognition of the problem and then getting that person in front of someone that knows how to optimally treat depression and depression symptoms. Another psychiatric issue that we sometimes see in individuals living with PCA is something that we call delirium. And delirium, hopefully, most often is just a temporary malfunction of the brain, and it occurs when any of a number of things impact the brain in a way that the brain's normal environment is disrupted. You know, for the brain to be happy, it needs certain things. It needs to have glucose, it needs to have oxygen. You know, there are certain things that if the brain is exposed to these things, it interferes with the brain's ability to function. And delirium kind of represents a global problem with the brain where many areas of the brain are just not functioning normally because of something in the brain's environment that's messing the brain up and not allowing the brain to function at its best. We see delirium in a variety of contexts. We know that there are certain things that predispose to delirium, and one of the things I worry a lot about is the role that medications may play in the development of delirium, because there are certain medicines that, when prescribed, can actually lower the threshold and make delirium more likely to occur. But whenever someone has a relatively abrupt change in how they've been, and their clarity of thought and their behavior, when anything that happens out of the blue that just seems quite odd, like they start having symptoms you've never heard them talk about before, like hallucinations, this is a big red flag that delirium needs to be considered as a possible underlying cause of what's going on. I've listed on this slide the defining features of delirium. And one of the things we see right away in someone who's experiencing delirium is inattentiveness. And it's sometimes kind of subtle, but I've learned to notice it sometimes by noticing that if I'm interacting with someone and I feel like they're being rude to me, that kind of makes me think, well, why am I thinking this person's being rude? And then I realize, oh, I know why they're being rude. It's because they're not focused on me. They're all over the place, and they're not attending just to me. And that can be one of the earliest indicators that there's a problem with delirium, inattentiveness. But other symptoms that define delirium include that the symptoms develop really quickly. We're not talking about symptoms developing over weeks and months. We're talking about hours or maybe a day or two when all of a sudden this change has taken place. We know that delirium, since it affects the whole brain, we're going to see all sorts of things going haywire in terms of a person with delirium having really lousy memory out of the blue, being very disoriented in a way that they've never been disoriented before, not knowing where they are, what day it is, where just a few hours ago or yesterday they knew all of that information. They may also have some changes in perception, as I mentioned a moment ago, where the changes can be so dramatic and their brain's function can be so aberrant that they begin to actually have hallucinations of various types. Often they can have visual hallucinations, again, different than any of the prior symptoms that they may have been living with as they've lived with PCA. So delirium really is a red flag that there's an underlying acute medical problem that's popped up. And it really means that this person needs immediate medical attention so that the underlying cause of the delirium can be identified and treated. You know it's delirium when the medical problem is treated and then the delirium symptoms go away. Some of the common causes of delirium can be urinary tract infections, pneumonia, but also medicines can be a problem. And we'll talk a little bit more about this, but there's a certain category of medications that we call anticholinergic medications. And these medicines really predispose to delirium. And many of us might be able to take one medicine that has anticholinergic properties, but if somehow we have 2 or 3 doctors and they're not talking to each other, and suddenly this doctor prescribes an anticholinergic medicine, and this doctor does, and this doctor does, now we're on 3 of them, at that point, there might be so much anticholinergic impact on the brain that that's what triggers the brain to slip into this condition that we call delirium and stop functioning normally. Another possibility, and sometimes we see psychosis in the context of delirium, but psychosis is a condition that's defined by the development of delusions, fixed false beliefs that don't respond to a rational argument to the contrary, hallucinations, which can be in all sorts of different domains, visual, tactile, auditory, olfactory, and then also psychosis includes disorganized thinking, where a person's unable to form logical and comprehensible thoughts as they speak. Their sentences are just all garbled. So, that's not the slide I wanted. So, in the most liberal sense, I'm sorry about these. I don't know how this Latin got on here, but we're going to talk about optimum evaluation and treatment of all of these behavioral symptoms. And in a liberal way, I think of behavioral symptoms as a form of communication. When someone living with any form of progressive neurodegenerative illness, including PCA, including Alzheimer's, including Lewy body dementia, whatever a person in that situation develops a change in behavior, I look at that change as a form of communication. It's as if the patient, maybe not in words, but through some other way, is really trying to give us the message that something's wrong. It's a signal that there is a problem. And so then our job as family members who are healthy or as clinicians involved in providing care, our job is to figure out what is that message. And once we identify it, of course, then to help with that problem. So, you know, someone may have a change in behavior, but they may not have words to tell us, but they may be experiencing pain. Someone may be having a change in behavior, and it may be because there's a communication breakdown, but they don't use words to say there's a communication breakdown. They express it in some other way. Also, we know that sometimes people living with PCA may have behavioral problems or symptoms developing because the environment has triggered them. It's too noisy, or maybe it's the opposite problem. It's too quiet, it's too boring. But we want to just remember that when someone with PCA has a change in behavior, it's a form of communication. If it's an abrupt change, as I was talking about a short while ago, maybe that message is this person's communicating, or their body is communicating to us that the problem is delirium. But it may be many other things, and we'll talk more about what those other things could be. So when we think about behavior change, sometimes it's helpful to break it. The causes can be broken into these different categories. So as a physician, of course, when I hear about behavior change, the first thing I think about is what might be going on medically that could be the cause of the change in behavior. And I've listed some of the more common things that we believe trigger change in behavior in PCA. And I've mentioned problems with prescribing, but also not making sure that the sensory modalities that they have are fine-tuned and corrected to the maximum ability. So, for instance, people living with uncorrected hearing loss may have changes in behavior driven by the lack of hearing. But we also know that other things can cause behavior change, like low blood sugar or untreated physical pain. Psychiatric conditions can cause behavior change. I've listed some of those up there. Psychological factors may trigger changes in behavior, and other things too, like being hungry or thirsty, or not even being able to move about. Maybe for whatever reason, a person has been in a situation where they've been stuck in a chair for 2 or 3 hours. And so if they're getting restless, we have to ask ourselves, well, maybe it's because they've just been sitting so long that their body is beginning to ache and feel uncomfortable. When someone with PCA has behavior change, as a physician, these are the questions I ask myself. I ask, could this be a new medical problem that's occurring? It would be sweet if being diagnosed with something like PCA gave that person a pass on any future medical problem. I wish that were the case. Unfortunately, it is not. But what can happen sometimes is everyone's so fixated on the PCA that it doesn't get noted that, well, yeah, they have PCA, but guess what else? They may have developed a new problem like hypothyroidism. And so we have to be aware that someone with PCA can have a new medical condition occur, and we have to be aware of it and able to look for it. They also can have pre-existing medical problems that get stirred up for all sorts of reasons. So, if someone's living with a condition like insulin-dependent diabetes, but somehow in the course of their PCA illness, their insulin doses and their intake of food isn't matching, it may be that they're constantly running low in terms of their blood sugar, and so the changes in behavior are really being driven by a problem with the management of the diabetes and really nothing else. And so the solution in that situation would be making sure that that person gets their blood sugars measured and makes sure that their diabetic medication doses are optimal. I keep returning to this thing called suboptimal prescribing or problems with medicine, but I do so because it's such a big problem right now. We're going to talk more about this, but one example of suboptimal prescribing is something that we call as physicians polypharmacy. And that just literally means too many medications. And boy, is it a big problem in our society today. And there are so many reasons for it. I think some of it is really related to the physicians and how we practice. I do worry about care fragmentation. I worry about doctors who don't talk to each other, and so they don't realize fully how many medicines a person is on. I also think that some of the issue may be related to how we've been spoiled by modern medicine, and we believe that there may be a pill for everything. And so if we go to a doctor's office and we don't get a pill, we sometimes walk out feeling like we didn't get our money's worth, when really many good doctors recognize that the solution isn't a pill, and they really shouldn't be prescribing the medication. It should be some other solution. Regardless, too many medicines can be a big problem, particularly for older adults, but especially for an older adult who might be living with a condition like PCA. Another thing that can change behavior is someone who's not taking their medication, and so physicians need to be certain that they're asking about what we call adherence. Is the person taking medicine and taking it as prescribed? As we've talked about, people with PCA can develop new and never before experienced psychiatric conditions like depression or anxiety. Of course, they can have pre-existing psychiatric conditions that aren't going to go away simply because they now are living with PCA. So if someone has a history of recurrent major depression or a history of panic disorder, those conditions need to continue to be monitored and treated so that they don't become part of the burden that that person is living with and coping with. And then, of course, also we know that drugs and alcohol can affect people's behavior. And as a physician, of course, we need to keep that in mind as we're trying to assess someone who's been brought to us and is being described as having problem behaviors, or they're self-reporting problem behaviors. We need to keep in mind that maybe it could be related to something like alcohol or non-prescribed medication use. As a person's brain goes through PCA and as additional injury mounts, sensitivity to things like alcohol can really dramatically increase. And that may not be something that anyone really appreciates, but it's something to keep in mind, that sensitivity to medicines and the recreational and kind of social things like alcohol the sensitivity can really change in PCA. So I mentioned suboptimal prescribing. I mentioned one of the most common forms is polypharmacy, or too many medicines, but these are other examples of prescribing practice that we feel leads to problems. And I'm sharing this with you because this might be a moment in your interaction with a physician or a clinician of some other background where you might want to speak up because you may be able to have a conversation that leads to a better outcome. We know that one of the issues that occurs as we grow older is we become more sensitive to medication. And I think that's a good thing. I like that aspect of growing older. It means I'm going to get more bang for my buck. And I think that's kind of a silver lining of getting older, that I won't need as much medicine to get the same positive outcome with a particular medication. But we do see a lot of doctors with good intentions using doses of medicine that are really not appropriate for someone who's older. A dose that might work beautifully in a 30-year-old might not be the dose that you would want to give to someone who's 60 or 70 or 80. So taking into account how age affects our body's ability to process medicines, metabolize medicines, and therefore maybe be more sensitive to medicines is something that's really important. We also sometimes see really unfortunate mistakes being made where a great example would be someone who needs to take a medicine for blood pressure that causes them to form more urine, and yet that medicine is given at bedtime. And of course, to me and to many physicians, that seems ludicrous, because if you give something called a diuretic at bedtime, guess what's going to happen? That person's going to be up all night going to the toilet. Their sleep is going to be disrupted. They're going to have an increased risk of having a fall because they're going to be getting up at night in the dark. They might be experiencing changes in blood pressure as they get out of bed. So we don't want to give medicines that cause a person to urinate more at bedtime. And yet I actually, in the 21st century, do see this happening. And again, this is something that should be avoided. And if it's happening, it needs to trigger a conversation with the physician or clinician who prescribed that medicine at that time. Suboptimal prescribing isn't necessarily always about too many medicines. It's sometimes about medicines that are missing, and that's a problem. We know that, for instance, one of the things that can happen as we grow older is that that our bowel slows down, and then we know that we might be prescribed medicines that actually make us more prone to constipation. And so sometimes the issue is that the physician or clinicians have set a person up to have really severe constipation, and we have to give a medicine that addresses that if those other medicines can't be reduced or eliminated. Also, pain being overlooked is another big concern, and we know that untreated pain is associated with all sorts of unwanted outcomes. A great example would be insomnia driven by pain that wasn't adequately identified and treated. So sometimes when we think about suboptimal prescribing, we're thinking about a medicine that is missing, that if it were added in, would make that person's quality of life much better than it otherwise would be. So there's a list now that's readily available on the internet. It's called the Bierce Criteria, or the Bierce list. It was originally developed back in 1997, but it's been repeatedly updated, and each update has been better and better. And this list is a list of medicines that have been found to, in general, be more harmful than helpful when given to an older adult. And so those of us who work a lot with older adults know that we should not be prescribing patients medicines from the Bierce list if we can somehow avoid it. So it might be an interesting exercise for each of you to go to the website, Google Bierce Criteria, Google Bierce list, get that list, and then just see how, if you're on any of those medicines or if your loved one is on any of those medicines. It might be worth having a conversation with the physician or clinician who prescribed that medicine to make sure that they know it's on the Bierce list and to make sure that they believe there's no other alternative. There are moments when that might be the case, but in many instances, there are better medicines available and a substitution can be made to a medicine that's been shown to be much more likely to be successful when given to an older adult. The most recent versions of the Bierce list are so well done that they have tables that say, if you're taking this medicine, it's not a good idea, and here are medicines that would be good substitutes. So I don't want to set any of you up for conflict with your clinicians or physicians, but I do think that there's room for partnership here and room for conversation. And sometimes a busy clinician may overlook something, and this is an opportunity, if that has happened, for that to be corrected so that on top of all the other challenges that you may be facing, at least you're not facing challenges that could be avoided if medicines were prescribed in a more modern and proper way. Okay. The worst example of probably polypharmacy is this thing called the Prescribing Cascade, and we see that a lot where someone goes to the doctor with a problem and gets a medicine and it fixes the problem, but dang it, it caused a side effect. And so they either go back to that same doctor or they go to a different doctor and complain about the side effect, and so then the doctor gives them medicine to treat the side effect. And maybe that second medicine fixes the side effect, but guess what? It causes a side effect. Now, this all seems so silly and so unbelievable, but it happens. And we see people who come in for care in our program that may be on 6 or 8 medicines, and it's all because of this thing we call the prescribing cascade. And what we have to do is we just have to take them away one by one. And we often discover that none of those medicines were really needed. All that was really needed was that the original medicine's dose be reduced or the original medicine be changed to a medicine that didn't cause the side effect. So we really want to look out for that kind of a situation. And it really is most likely to occur when multiple clinicians are being consulted and involved in care. Now I'm going to switch gears here and talk about some other things like a rested caregiver is a more effective caregiver. I think that it's important that I just emphasize this. My experience has been that it's very easy for those of us in a caregiver role to overextend and to give too much, and that can be a very dangerous thing. It can lead to all sorts of avoidable problems. We worry about the caregiver's health, and we recognize that the caregiver and the person with PCA are a team. They're a partnership. They're a unit, and they both need to be at their best for things to go forward in the best way possible. And so certainly we don't want anything to happen to a spousal caregiver or a primary caregiver because they've been shortchanging themselves and not really making sure that their basic needs are met. And so it's really important that the caregiver focus on him or herself as well as focusing on the individual with PCA. It's a slippery slope. It's a tricky thing, and I get this. You know, when we have a loved one who's living with an illness that we don't have especially, it's only natural for us to want to show our love through action, through taking care of that person, for trying to make that person's life better. It's just what we do. It's how we show love to one another. But there has to be a balance here. And so it's really important that as you live with this illness, that you are taking advantage of resources in your family, in your community, that can really help caregivers get a break and stay healthy and not put themselves in danger. We need to have caregivers establish realistic expectations for themselves and for their loved one so that you avoid being on kind of a roller coaster where you have certain expectations that aren't fulfilled and then you're disappointed and it just starts all over again. So it's important that you have realistic expectations for yourself and what you can accomplish in a day. It's important that you also have realistic expectations for what your loved one might be able to accomplish. It's also important to not overgeneralize, and this is another challenge that we all have, I think, when we work with someone living with PCA or any of the other progressive neurodegenerative illnesses. We're often tempted to think that because this one part of the brain isn't working, that none of the brain is working, and that really isn't the truth. And if we make that assumption, it often does not work out very well. One of the easiest errors I see being made is when we don't appreciate that even though this person may not see and understand the world visually as well as he or she used to, they still may have other parts of their brain working quite well, including the part of their brain that allows them to understand and respond to emotions. So emotional intelligence is often preserved all through the illness. So we have to be very careful that even though a person may not use words as fluently as they used to, they're going to be able to look at us, see our face, hear the tone of our voice, appreciate the volume and the rate of our speaking. They're going to have the ability to find other ways to get a sense of the emotions of the moment. And so we want to be very careful that the emotions that we're displaying are ones that are going to be helpful and not emotions that are going to make a situation more problematic. Now, none of us are perfect, but an example would be, if at all possible, it's a very important thing when someone with PCA has an issue related to their vision that causes them difficulty, that we wouldn't scold them. We wouldn't make them feel badly about that because it's not something that they can really change. And so we have to be very careful not to unintentionally make someone feel ashamed or embarrassed. And we may have to teach other people about that too. Other people who aren't as familiar with this condition, we may have to spend some time bringing them up to speed so that they also are aware of this. Communication is really important, particularly when someone isn't able to use vision as they used to be able to. That's going to limit their ability in the realm of communication. Many of us, as we grow older, we lose a little hearing, and yet whether we're conscious of it or not, those of us who've had some hearing loss may have developed the ability to supplement hearing with understanding how the lips move and doing a little bit of lip reading. When we can't quite hear that word, we can surmise what it was because we've seen how the lips moved as it was being produced. But if you have PCA, that won't be necessarily as likely to be possible. And so we have to just be really careful about making sure that we communicate in ways that are successful. And some of the suggestions here include, making one request at a time and making sure that that request was accurately heard and registered before we move to something else. Another issue would be speaking too fast or speaking with poor diction. Again, keeping in mind that there may be some hearing loss and there may be some also changes in vision, and that interaction may be making it harder for that person to really hear what's being said as well as they might have in the past. Another issue is being patient and making sure that after we've said something, we pause and make sure that that person can respond to us. And this takes practice because you've lived with people, you've gotten to know them quite well, you kind of know their pattern and rhythm of speech. You've been doing that for years, perhaps decades, but here's a moment where those habits will have to be reassessed, and you may have to recognize that even though 10 or 20 years ago this was the way that you spoke back and forth, it has to change a little bit now so that there's more accurate and successful communication. And here at the bottom, I've listed not using more than one sensory modality can be a problem. Now, for me, just by the nature of my personality, I tend to be someone who, uses gestures a lot and raises and lowers my voice, and so I kind of naturally am speaking and communicating with more than just one modality. But if that's not been your style, you may find that trying to incorporate other ways of delivering the message that you want to deliver can be useful. Eye contact is still important. We don't always understand exactly what that person with PCA is able to see and not see, so it's really important that we assume that they're being able to notice us and notice our eye contact and our body posture, so it's really important that we continue to look them in the eye when we speak with them. It's important that we monitor our posture because they may still be able to interpret whether we're standing in a tense way or a relaxed way. I mentioned earlier when we were talking about grief that sometimes one of the things we can do that's very helpful is taking a moment to notice what the patient's expression or the person's expression is and put it to words, because maybe they haven't been able to in that moment. But if you do it, it's a good thing because they appreciate that you've taken the time to understand where they are in that moment. Using simple, direct statements is also another good thing to strive for in communication. So we do sometimes need medications when we're helping people with various psychiatric and behavioral challenges that may occur in the context of living with posterior cortical atrophy. We tend to prefer certain types of medicines because they're going to be safer and less likely to cause problems. In general, when we work with older adults, geriatric specialists really love medicines that don't depend on the liver to be metabolized and excreted. We like medicines that go through the kidneys, and that's simply because we see fewer worrisome or significant drug-drug interactions with medicines that are renally excreted. We really want to be careful that we're tracking the impact of whatever medication may be used. It's important to make sure that the initial dose is low and that increases are made slowly with careful monitoring so that we really understand the impact that the medicine is having. We strive to use the lowest possible dose, and we actually also recognize that sometimes we'll see behavioral symptoms at one point and a year or two later they may not be there. And the only way that we can sort that out is at some point for someone to ask, are these medicines still needed? And maybe if the person has had a period of extended stability, it would be the right time then to begin incrementally reducing the dose with spaces in between so that the impact of each dose reduction can be assessed. If we make a dose reduction in a medicine and the symptoms that were there originally return, then we just have to return to the previous dose and maybe wait another 3 to 6 months before considering another attempt at dose reduction. It's really important, though, to remember that PCA is a moving target, so we don't want to just come up with a recipe, put it in place, and forget about it, because that wouldn't be providing optimal care. We actually sometimes are able to even discontinue medicines as a person moves from one phase of the illness to another. Okay, you guys have been really attentive. I've been able to see some of you on the screen, and I thank you for that. I'm going to pause, and I have time for questions and answers if you all do, and I just want to make sure that I know how to be able to hear you. So let me figure that out.
So do you hear me?
I hear you just fine.
Good. So people are going to raise their hand when they have a question. I will call on them. I will unmute them, and they will ask a question. And we're going to now.
That sounds great, Jamie. And by the way, Jamie, just so you understand, I only see, I think, 4 of you.
Okay.
So I may not see the person asking the question, but I appreciate your helping connect us.
I will do that. And so I will ask right now, thank you so much for that. And what I think I'm going to do is maybe cut off the first part of your talk because we did like the Seb Crutch's slides, we know those, and start when you started talking about the behavioral stuff that you do. So it worked out.
That's fine.
Beautiful. I will now take questions. If you are on the phone, you can do a chat with me. You can do a chat with me, and just a second, please. You can do a chat, and I will ask the question if you write the question in there. Okay, so anybody have a question for Dr. Sewell? Yes, Hal, I'm gonna unmute you. Go ahead.
Thank you. It's not so much a question. I really want to thank Dr. Sewell for this talk. She has sorted out a lot of things that I have felt or experienced or wondered about, but could not interpret. You know, I think that it would be wonderful if everybody who has PCA should get a chance to hear something like this and have their caregivers with them to hear it.
Wonderful. Thank you so much, Hal. Thank you. Any questions, comments? I see if you're again on the phone and you have a question. Yes, Kathy, I will unmute now. Go ahead. Kathy, can you unmute yourself? It's not letting me unmute you.
Thank you, Dr. Sewell. This has been one of the most informative webcasts that I've seen since I've been on these past months. My husband has decided that he just wants to be left alone. He doesn't want to engage with people. He doesn't want to, he just wants to go be in his dark room and just shut out the world except for meals, etc. His neurologist took him off of Memantine, and I've noticed that he's now having a very hard time articulating, expressing what he wants. He knows, but he can't verbalize. And I'm wondering if the Memantine being off of it, he's been off of it for almost a month, and we do have an appointment in another 2 months to be re-evaluated, which he doesn't want to go through. But I'm just kind of seeing him diminishing, his capacity diminishing, and I can't do anything about it.
Well, Kathy, let me just first say I'm so sorry. I hear the emotion in your voice, and I appreciate what a difficult journey that you and your husband are on. There sounds like there are kind of two questions. One is, some of what you said does make me have concern for the illness depression, because symptoms of depression do include social withdrawal and isolation, and it also seems like his energy and his motivation have gone because he just wants to be in his room alone most of the time. It sounds like maybe one positive is that he is still having appetite and eating, but one concern I do have, based on what little bit you've shared, is that he might need a careful evaluation for the illness depression, because it is something that we treat, and we treat with fair success now in the 21st century. And if it's not a panacea, but it certainly will make his quality of life better, and also indirectly make your quality of life better as well. Now, the other question I heard in there was a question about Memantine. And the idea there is he was on it, it was stopped. Did you notice that after it was stopped that he seemed to have more symptoms, or his symptoms worsened?
No, they were almost the same, except now there's been a rapid decrease in his ability to communicate, and he's aware that he can't communicate. And I think that's one of the things that's exacerbating his wanting to be left alone, because he knows he can't make his thoughts and feelings. He can't express himself. So he's embarrassed by it. And he doesn't want to be around people because he can't communicate.
Yeah, understood. Well, I'm gonna restate this just to make sure I understand accurately. It sounds like after the memantine was stopped, his ability to use spoken language dropped off.
Yes.
Then,
Yes.
then that my concern then is that there may be, it's not a causative association, but it's what we call a temporal association, and the relationship between the discontinuation of the memantine and the change in his ability to use language, spoken language. I'd be concerned that there could be a connection there, and it might be worthy of a discussion with the doctor who stopped the memantine to let that doctor know that you noticed that the stopping caused a change in his language, and maybe it should be reinstituted.
Thank you. Thank you very much.
Yes, and then there was one other thought. Oh, and then I understand that he might want to isolate because he can't communicate, and you know, for people who don't know what he's going through, they're not going to get it, and they're going to probably make him feel embarrassed or awkward or whatever. But one thing to think about is ways that you may help him communicate better, not using words. And there are different ways that you might explore that he would be able to get his ideas across, even if he can't use words. So that would be worth exploring. You know, this isn't the best example, but it's the first one that comes to my head. Depending on how much vision he has still that he can lean on, you know, if he can't speak, maybe he can point to a board with items on it. Maybe he can write in big letters, something like that, because until we figure out a way to possibly get his speech back in place, it's still going to help him to feel understood and to have some ways of getting what's on his mind and in his heart across to you and to others around him.
Thank you. I'll look into that.
You're welcome. You're welcome.
Thank you so much, Kathy. Thank you. Anybody else? I am going up and down looking for hands. And anybody on the phone? Okay, well, I am going to just say thank you. Thank you, Dr. Sewell. You're welcome back anytime. And we will have this posted. And again, this was invaluable because I don't think anybody's ever come on and really spoke in depth about many of the concerns that caregivers feel. Oh, we do have a question.
Sure.
Oh, no, it's not a question. Somebody says this was a fabulous lecture.
Well, thank you. Thank you for those kind words to all of you who have given me such nice feedback.
Thank you, everybody. And I just want to make note that our support group for patients only is tomorrow, and I'm going to send everybody information on that so you have the logins. Dr. Sewell, thank you again so much.
You're welcome. My pleasure. Take care, everyone.
Thank you.